Welcome to the Cairo Up 15 Minutes to Excellence webinar, where our goal is to provide you with some useful new skills in 15 minutes or less. I think you're going to enjoy this presentation of dysfunctional breathing. It's part 5 of our Explosive Outcomes series. I think we named explosive outcomes properly because clinicians who can identify these 7 underlying functional diagnoses are typically going to get much better outcomes than those who can't. Traditional structural diagnoses focus on a tissue for the patient's symptoms, much like a facet capsule or a supraspinatus tendon, whereas dysfunctional breathing is a functional diagnosis that requires identification of the underlying factors that contribute to those structural lesions. These conditions are the ones that, if missed, give us a bad name because they prolong the patient's treatment plan and they lead to recurring problems. So dysfunctional breathing refers to a whole group of disorders that could be paradoxical breathing, which can be thought of as upper chest breathing, could be erratic breathing, breath holding, or breathing too deeply. In addition to oxygen deprivation, these can also lead to some biomechanical problems. The diaphragm is necessary not for just respiration, but for core stability as well. The diaphragm is really a key stabilizer of the trunk, especially during activity, and it has to activate upon demand. If we don't rehab these problems, the patient's outcomes are going to suffer. Core stability is largely determined by intra-abdominal pressure. In that increased intra-abdominal pressure is going to lead to improved spinal stability. And the intra-abdominal pressure is determined by the strength of the muscles forming the canister of the abdomen. This canister is made up of the transverse abdominis muscles and intercostal muscles as the front and sides. The lumbar erectors and paraspinal muscles and multifidus muscles serve as the back of the canister. The floor of the canister includes the muscles of the pelvic floor, and the diaphragm serves as the roof. And together, these muscles regulate intra-abdominal pressure and thereby core stability. The stability requires a complex synergy between all of these canister components. The process begins when the diaphragm contracts and almost a coactivation of the muscles of the pelvic floor. This is followed by an eccentric contraction of the abdominal, intercostal, and lumbar erector muscles, and together these muscles increase intra-abdominal pressure. Let's take a look at a video that can help to understand. The can on the left is still sealed, and when we apply a pressure, the can remains stable. The can on the right in this example is open, and we see that it's unable to pressurize and it becomes unstable when a load is applied, and the same thing happens when the diaphragm isn't functioning. If we think about it a different way, trunk bracing protects the spine in a neutral position throughout movement, and a well-braced core provides stability, much like this battleship provides stability for its large guns, much better than this rowboat is going to provide stability for firing that cannon. The other thing that diaphragmatic function plays a role in is joint centration. Joint centration and functional stability allow a joint to remain in their neutral or centrated position throughout movement. This means that the joint is in its optimal surface relationship. And in order for a joint to function at its peak, it has to remain centrated. If it's not, this places the surrounding tissues at a disadvantage. So this leads to sprains and strains and osteoarthritis. The types of things that patients with dysfunctional breathing patterns complain about. This ranges from the local types of problems to more significant problems. Literature tells us that even disc lesions and spondylolisthesis may be related to dysfunctional breathing patterns. And inefficient diaphragmatic contraction certainly destabilizes the spine, and it causes overactivation of the associated muscles, the spinal erector and the other core muscles, so we're going to get myofascial pain. And we know that all of these things, if they perpetuate long enough, can lead to degeneration. So really, dysfunctional breathing is related to a lot of the problems in the core and trunk and hips throughout the spine. We can imagine the diaphragm as a parachute, and normal breathing occurs when the diaphragm contracts. That causes it to flatten and thereby pressurize the abdomen, and in turn then the abdomen expands as well. And that has to occur in a sequence. The diaphragm has to initiate pressurization. It has to contract before the abdominal wall. But demands for stability don't always coincide with the initiation of a breathing cycle. Sometimes we need to throw a sandbag in mid-breath. Well, fortunately, the body is able to co-manage that task. It can pressurize mid-cycle. But that's dependent upon activity and dependent upon the person. That the body is usually able to co-manage its task during brief isolated movements like picking up a coffee cup or reaching for a doorknob, but when we have sustained or repetitive movements, those can pose more of a challenge. the body's ability to manage that task also varies fairly dramatically between individuals. When we assess for how an individual manages that task, we're going to look for signs of dysfunctional breathing. You can read the list here. They range from elevation of the rib cage, labored breathing, yawning, mouth breathing, but really the two most common things that we're going to see are elevation of the upper rib cage and initiation of breathing from the chest rather than the abdomen, and we call that paradoxical breathing. In a normal breathing pattern, the chest should remain relatively still. Patients who breathe paradoxically typically have their abdomen remaining relatively still while the chest and shoulders elevate and expand. The way that we're going to assess for this is by having the patient lie on their back. We're going to have the patient place one hand over their umbilicus, the other hand over their sternum, and ask them to breathe. The initiation of a deep breath should start in the abdomen with minimal evaluation of the hand. The other way that the clinicians can assess for this is to stand behind the patient with your hands on their rib cage and upper abdomen, and we apply a light pressure, and we should feel resistance back as the patient breathes in and breathes out. And we want to see that that pressure kind of maintains throughout the normal respiratory cycle. If the patient's not breathing properly, they're going to overuse muscles, and these are the muscles that are secondary sites of irritation: the upper trapezius, the scalenes, levator, SCM, and pectoral muscles. So we need to make sure that when we treat the patient, we're looking for trigger points in myofascial irritation in those muscles. And you can check the ChiroUp protocols for any of the muscles involved and make sure that we're getting the trigger points worked out. Then we also want to teach the patient how to breathe properly, and it's important to do this before we retrain the other core muscles. Diaphragmatic function needs to be restored prior to initiating balance and stability exercises, because patients with inadequate diaphragmatic function and poor stabilization aren't going to benefit as well as those who have already learned breathing mechanics. Think of the can example. It doesn't make sense to increase the sides of the can if the lid is still open. So how this starts is, first we're going to educate the patient about how their mechanics contribute to their symptoms. We're going to describe how their specific breathing is abnormal, and then we're going to allow the patient to experience that. We want them to recognize their fault by putting a hand over the abdomen, a hand over the sternum, and then also observing themselves in a mirror so that they can see how things are happening improperly. Then as the clinician, we want to demonstrate normal breathing mechanics so they can see how that works. Here's a video of how the patient is going to do this exercise at home. They're going to begin lying in a hook-lying position, supine. They'll place one hand over their abdomen, the other hand over their sternum. We'll advise them to breathe in slowly and deeply through their nose and make sure that only the hand over their abdomen rises. The clinicians need to stress the importance of abdominal expansion in this whole process, that the abdomen needs to move, and you can enhance this by having the patient lightly compress their abdomen when they breathe in. They can either compress just anteriorly from the front, or they could reach to the sides, applying a light pressure and trying to maintain that resistance against the lateral rib borders as they inhale and exhale. Then we're going to have the patient perform this in progressively more challenging positions, like knee to chest, moving to seated, standing, and finally, while performing dynamic movements like an overhead squat. The other thing that's important is to make sure that the patient is breathing with a proper rhythm, which should be 1 second of inhalation for 2 seconds of exhalation. So typically it's going to be 2 to 3 seconds inhale and 4 to 6 seconds of exhale. If the patient is exhaling too quickly, you can have them exhale through pursed lips, and that can increase that exhalation time just a little bit. So the ultimate goal of any core program is to increase stability. We want to have the patient be able to subconsciously maintain centration and mechanics throughout their activities of daily living, so that when they throw a sandbag, their core remains stabilized the whole time. In addition to training the diaphragm, once their proper mechanics of breathing have been restored, the patient could also benefit from some abdominal bracing exercises, planks, bird dog, dead bug, things like that. So how do we implement this in practice? You go to the ChiroUp condition menu, circle dysfunctional breathing, as well as any other diagnosis the patient may have, and everything happens automatically from there. Your patient now has the most appropriate exercises and ADLs and makes themselves an active participant in their recovery. If you need to review any of the things we talked about today, go to ChiroUp, check out the Clinical Resources tab, and review Dysfunctional Breathing for videos of any assessment or treatment that we talked about. I hope you've enjoyed this presentation, and we look forward to speaking again.